question, and I will, of course, give you some personal thoughts on that. I have no financial interest in these studies, and the topics I want to talk to you is first, what are the key data of BioResort or 23 study and the BIONICS trial? How do you put these studies into perspective related to other studies? Then the key question is, did these studies change my everyday practice? This is always the same question. When you come home from TCT, the next day you go to work, did it change anything you do? And I will come to some conclusions. So let's start with the key data of these studies. I'm sure you have seen this in the late-breaking trials of both studies. The BioResort study, presented by Clemens van Birgelen here in the panel, was a randomized trial, I think a very important randomized trial, comparing the durable polymer drug-eluting stent, the Resolute Integrity, with the biodegradable polymer drug-eluting stents, two different stents, the Synergy and the Orsiro. So these are two very modern, up-to-date drug-eluting stents with biodegradable polymer. And as you can easily depict here from this slide, they are really different. The Synergy has abdominal coating, whereas the Orsiro has circumferential coating. The metal is different, platinum chromium versus cobalt chromium. So when the coating disappears, this is what the coronary artery sees. The polymer is different, and interestingly, the degradation time is very different, 4 months versus about 2 years. So about 3,500 patients were randomized, and these are the results of the primary endpoint, and as you can see, there's no difference. The scale is a little bit exaggerated, so this is actually 0.7%, which is absolutely non-significant after 1 year. And safety, also the same. Again, the scale is very exaggerated, so this is 0.1% difference here. So there is no difference. These stents are shown the same safety and the same efficacy. What about the other trial, the BIONICS trial? It compared two stents, also the Resolute as a comparator, together with a new made in Israel by Medinol stent here with Rida Forolimus. I have to read this because I'm not familiar with this new Limus drug. It has a new stent design. It's a polymer, but a durable polymer, and it has a nice delivery system. Well, this was also a randomized trial, approximately 1,000 patients in each group. And here comes the primary endpoint, which was also a clinical endpoint, target lesion failure after 12 months, and absolutely identical, the BIONIR and the Resolute stent. And regarding safety, as you can see here, regarding stent thrombosis and the timing, there's absolutely no difference, with very low rates of stent thrombosis in both groups. So how does this fit into perspective? The question is, was the Resolute the right stent to be used as the reference stent? As you know, many people say the science, that is the gold standard. Or would it have been more appropriate to have chosen the science drug-eluting stent for reference? I just want to recall you the Resolute all-comer trial, which I had the honor to be together with Patrick Serrois and Stefan Windiger as a co-PI. And the primary endpoint was a clinical endpoint. And the results after 5 years, we've published this, absolutely no difference in the primary clinical endpoint, and also in stent thrombosis, no difference. And I was very happy that the Dutch group from Twente actually did a similar study comparing also the science and the Resolute, and these are the primary endpoint. And as you can see here, after 3 years, absolutely no difference between those two stents regarding also stent thrombosis. And recently, even the 5-year results were published totally identical with other results. So thanks to Clemens to confirm the hypothesis that actually the Resolute is also a gold standard stent. Was the Resolute the right drug-eluting stent to be used as a reference? So the answer is yes, this is also a gold standard stent. Which brings us to the next question: were the results of BIONICS expected or were they unexpected? Well, there was a previous study, the Nereus trial, which had a primary angiographic endpoint, also randomizing the BIONIR with the Resolute stent. And as presented at the EuroPCR, the curves here of instant late lumen loss are really identical, so you would not expect really difference. So interestingly and luckily, at this meeting, the 12 months clinical results of the NEREUS trial were presented, and absolutely showing no clinical difference between these two stents. So the results of the BIONICS actually were not really surprising. The answer is no, they were not unexpected. Did these studies change my everyday practice? Well, the answer is no. Why? Because I'm not using drug-eluting stents with a biodegradable polymer anyway. And the Resolute is my workhorse anyway. So when I come home, actually, I'm happy to have seen the studies, but it does not change my everyday practice. So last but not least, we come to the following conclusions, or I come personally to the following conclusions. The concept of avoiding durable or even any polymer on drug-eluting stents is intriguing, theoretically at least, because many of the late events might possibly be due to polymer-induced neoatherosclerosis, late neoatherosclerosis. However, neoatherosclerosis is also occurring with bare metal stents, so this is not the only reason for the late problems. So far, no evidence-based clinical data exist showing superiority of biodegradable polymer-based versus durable polymer-based drug-eluting stents. At least to me, none of these data are really convincing. Today, even the opposite, a protective effect is discussed by some polymers. So maybe polymer is even a good thing to have on the long run. And modern drug-eluting stents with durable polymers are the gold standard, at least the ones I've shown you, and hard to beat. Maybe we are already at the limit, which cannot be improved anymore. And last but not least, and this is my personal opinion, avoiding biodegradable polymer-based drug-eluting stents does not put the patient at risk. They were all the same, and saves healthcare costs. So I think it's a very good situation that you treat the patient optimally and still save money. Thank you.